Mr. Griffith for 5 minutes.
On a personal privilege to begin with, I do want to thank you, Mr. Chairman. It's been great serving as your vice chairman, and if we have another hearing, that'd be great too. But you've been a great chairman and just all around good guy, and I appreciate having worked with you these years. Thank you. I do think that and I forget now who the testimony was from, but I do think it's important that we recognize it's both a health concern and a law enforcement concern. And so I've rearranged the way I'm asking my questions. Ms. Frederick Hawley, can you tell me a little bit about how your hospital and the Sexual Assault and Violence Intervention Savvy program partner with law enforcement and how that partnership benefits your patients?
Absolutely. One of our funding sources, the New York State Division of Criminal Justice Services, implemented that we have sexual assault task forces in all of the boroughs of New York City. So, for instance, the work that we do in Manhattan once a month, it's the Special Victims Bureau of the Manhattan DA's office. It's the Special Victims Division of NYPD for Manhattan. It's us, it's other SAFE programs, it's other community partners that all come around a table and discuss different issues that arise. It has a benefit in two ways. We get to discuss cases and ongoing issues, but we also get to develop relationships such that if there is a concern about something that is going on with law enforcement around a particular case, I can very easily pick up the phone and call special victims in Manhattan and say, I need help with this. And they're very responsive. So we have the good fortune where I work that it's sort of built into our model that we work with law enforcement.
And as a part of that, have you found that, obviously the victim, when they first present themselves to the medical providers, are distraught and not necessarily thinking clearly. Has it been your experience that it's later that they realize how important it is or how they want to have some emotional closure or solace from the fact that the case is brought forward and that the evidence is preserved?
The last time we did a statistical analysis, it was about 67% of our sexual assault survivors report to NYPD during the time that they're in our emergency department and turn the kit over. The rest, we hold them in security, and then we continue to follow up with them until they make a decision. Many times they don't. Lots of times, without certain supports in place, they could fall through a crack. So if it's just them working with NYPD, the likelihood of being able to carry forward under that kind of condition of trauma is, it's very challenging. So the more we can be involved and support them, the better the outcome.
I appreciate that. Ms. Jennings, we've heard about the lack of appropriate transportation to the nearest sexual assault forensic examiner, and that is sometimes a barrier. I know you work in the Richmond area. My district is between 3 and 7 hours away from Richmond. One hospital that received our letter noted that they may provide a sexual assault patient with a taxi voucher. Obviously, that can create problems on the criminal justice side because it can possibly corrupt the evidence. You got to go through a whole line of what happened in the taxi cab, what kind of taxi cab was it, et cetera. And so that creates a real problem in the criminal justice system. So that being said, for survivors that visit a hospital that doesn't have a sane nurse on staff or does not provide that, how do we best transport these victims to another facility?
And it's interesting that you actually asked that question. Recently in Virginia, we do have about 13 healthy forensic nursing programs. And our program experienced a patient that presented to us after traveling to 3 different hospitals being told, there's not a forensic nurse here, there's no way to do a sane exam here, go somewhere else, and not provided with the actual facility. In regards to the transportation, what we primarily see is the patient either being transferred by ambulance, so they'll go from one facility to our facility via an ambulance provider. So there's 2 people in the back potentially with the patient, but also law enforcement does transport some of these patients. Best case scenario is that the patient knows what hospital to go to, obviously.
Right. And obviously I represent a large and very rural district. Telemedicine, you touched on that in your written comments. I'm a big fan. It may mean more witness time for certain sane nurses, but What do you suggest on telemedicine if there's a rural hospital that doesn't have somebody, doesn't have the money to have somebody with the training?
I do see benefits of telemedicine. I think that one piece of it, there needs to be a very well-trained forensic nurse on one end, and then the nurse on the other end does need to have some basic training in forensic nursing. It may be a very brief course on evidence collection, but they need to have a little bit of knowledge prior to having that telemedicine piece set up.
And my time is up, but I do want to find out at some point, I may ask a written question later about the clinical component, what we can do to make that better. Thank you. I yield back.